Thank you. So I am an endocrinologist by training, and the field of endocrinology is the field of hormones. So you would expect that I am a menopause and hormone expert, correct? Right? We can all agree. But you would be very, very wrong. And that is because I trained at UCSD, and in a lot of healthcare institutions, endocrinologists are not the ones who are treating menopause. That usually goes to gynecology department, and at UCSD, that's where it was. So I have never started a patient on hormone replacement therapy. This is my first menopause conference. Okay, so in some ways I feel very underqualified to be giving this talk. However, in 2019, so 7 years ago, I started working at the Scripps Clinic Center for Weight Management. For those of you who are not aware, Scripps has a dedicated weight loss department that's within the Department of Endocrinology. And I'd say about 80% of my patients are women, and half of those women are coming to me with concerns regarding weight gain during the menopause transition. So late 40s, early 50s, even into their 60s, who are talking about what happened during the transition. So I have become an expert, at least in the weight gain associated with menopause, and I came for the whole conference today to really improve treatment because it seems like this is an area that really needs more participation, research, and clinicians. So that is my disclaimer. I do speak for Lily. Patient, this is Michelle. She's a 52-year-old woman. She has a history of hypertension and prediabetes. And she has struggled with her weight since her early 30s with some yo-yo weight pattern. She's tried a lot of different diets, but overall was pretty well able to manage her weight to a satisfactory degree. But in the last few years, she really endorses this increased central weight. Her last period was just over a year ago. She comes in and she says, I feel like I look like I'm pregnant. People have asked me if I'm pregnant. I feel very uncomfortable. I know something is wrong with me and something is wrong with my hormones. Is there something that you can do for me? And one of the speakers earlier said, yes, there is something wrong with your hormones. She's tried every diet, as a lot of people in this room, a lot of people in the 90s and early 2000s. There have been hundreds of diet plans out there and fads, over-the-counter supplements. She's also tried phentermine, which is a prescription weight loss medication. She's very active. She's a nurse at Scripps. She has their HMO healthcare plan, and her BMI is 36.3. So what is the next best step to help Michelle? And there is no one right answer. I just want you to be thinking about these things as we go through the presentation so that at the end I'll ask the same question and perhaps you'll have a little bit of different insight. So A, being a supervised dietary and exercise program. Start metformin. She has prediabetes. Maybe that will help with diabetes prevention. Start hormone replacement therapy. She's coming to see you with the hopes of weight loss. That is her main concern at this visit today. Add an oral obesity medication such as phentermine or phentermine topiramate. Add an injectable obesity medication like semaglutide or tirzepatide, or consider bariatric surgery like a gastric bypass or a gastric sleeve. So why is she gaining weight? Unfortunately today, by going last, a lot of my slides have already been covered by other speakers. So I'm gonna skip a lot in the hopes that we get back on time just for this, everyone's Saturday afternoon and evening. Why is she gaining weight? We talked about this. Weight gain is common in menopause, an average weight gain of 1.5 pounds per year in midlife, not just from menopause, but from a variety of other factors, including aging. Over 50% of women age 40 and above have obese range BMIs, and over 60 to 75% have overweight BMIs. And here's just a BMI chart reminder. BMI above 25 is overweight, above 30 is considered obesity. The cause is multifactorial. A lot of it is related to estrogen deprivation that increases body fat and leads to a decrease in lean body mass and less muscle, which can affect your metabolic rate, even if your overall weight is unchanged. This fat accumulation really tends to be more visceral, seen with this abdominal weight gain. So a lot of women will say that they used to gain weight in a different distribution, but now it's very central. They feel like they have this stomach. They feel like they look pregnant. Then there's this caloric imbalance. They might be eating the same way that they were before, but less active, and that can lead to further weight gain. So this is just showing some of the different factors that are associated with this weight change, including these hormone factors. An increase in ghrelin, which is a very potent hunger hormone, and when women are not sleeping very well, ghrelin can go up, so appetite can increase. We talked about all these other changes in hormones. Lifestyle factors change. As people get older, they tend to be less active, so they're burning less calories per day, maybe drinking more, sleeping less, smoking. And then other age-related factors, such as a decrease in resting metabolic rate, an energy expenditure, and a decrease in this muscle mass. So all of this leads to an increase in cardiovascular disease risk, which I know you guys have heard about yesterday and we've talked about today. But there are so many complications associated with obesity, right? Every organ system is affected by increased body weight. So on the left is talking about a lot of the traditional things that we talk about: metabolic disease, cancers, biliary disease. But on the right, I added this in. There's also an increased likelihood of menopause symptoms in people with increased body weight, an increased risk for dementia, and we've talked about people having brain fog or memory changes in menopause. There's impact on mental health, sexual function, personal social costs, professional employment, which are all things that menopause all seem to influence. So in some ways, it's this vicious cycle where menopause can cause weight gain, but weight gain can also affect other things that menopause is having a deleterious effect on. So how much weight loss is needed in order to reduce complications? I just threw this out there because I'm going to talk about what % of total body weight loss is expected with different interventions. And in general, we're kind of looking for at least 5 to 10% of total body weight loss in order to have significant improvement in complications or in risk reduction, okay? And that is 5% of total body weight. So if someone is 200 pounds, 10% is 20 pounds, 5% would be 10 pounds of weight loss. So why hasn't Michelle been able to lose weight, right? She's tried every fad diet, she exercises. And the truth is, historically speaking, lifestyle interventions to lose weight don't work. And I know that's really depressing. And I feel like this is like the pinnacle of the depressing talks that we've had today, because I have such dread for my future as a woman and menopause and all these different things. But in any case, people can lose weight. Hundreds of different ways that we can get people to lose weight: low carb, Atkins, HCG diet, HMR, Optifast, Medifast. The problem is the weight does not stay off. And everyone believes that it is a problem with their motivation or their willpower. And if they wanted it badly enough, they could put those habits into place, lose weight, and keep it off long term. But I always tell patients, unfortunately, well, fortunately too, because it takes some of the burden off of them, your weight is not that under your control. You can try to starve yourself, calorie restrict, exercise, but your body has evolved to survive, and it will do everything it can to regain that weight. And that's a healthy thing to do. It's just not healthy in this environment, right? We did not evolve. We haven't had enough time in this environment to evolve and adapt to it. So unfortunately, you can see on the top, it's showing that despite losing weight initially, almost everyone regains the weight, sometimes above where they started, because their brain set point increases to make sure that they never starve again. And this is for survival, okay? So Albert Stunkard is one of the grandfathers of obesity medicine. He was a psychiatrist. He started really doing research in the field where no one was researching it all that much. And he has this quote that I love that says, "Most people with obesity will not stay in treatment. Most will not lose weight. And of those who do lose weight, most will regain it." And unfortunately, this holds true today, 70 years later, when it comes to lifestyle interventions, right? And you probably have patients who have lost 50 pounds, 100 pounds, 30 pounds over and over and over again. And each time it just gets harder. And part of it is because when they lose weight, they are also losing muscle, but when they regain the weight, they're pretty much regaining fat. So even at the same weight, now they're older and they have a higher percentage of body fat, they're worse off than they were before they lost the weight. It's this horrible cycle, but your body evolved to do this so that you would survive. And women survive really well, right? In famines, women seem to do well. I don't know if you guys remember the Donner Party where they all went out west and they got stuck outside of Tahoe near Truckee, and the women did really well, you guys. So there is an advantage, and if we were in a critical environment, this would be good for us, right? It's just not good right now. As you lose weight, your body responds by lowering your metabolism and increasing appetite. So people think they lose motivation, but really it becomes physically impossible for them to stay on a restrictive diet, whether it's restrictive calories, restrictive carbs, whatever it is that they're trying to do. But lifestyle is still important, and I'm going to talk about lifestyle because it is still the foundation for successful weight loss, but we often have to couple it with other tools to help people lose weight, and more importantly, keep that weight off long term. So diet is the foundation for successful weight loss, but all the other things, medication, surgery, behavioral interventions, they work by influencing what you're eating. As this is from the ADA, the American Diabetes Association, but I think it applies to people without diabetes as well. There is no one size fits all. If you are only recommending one type of eating plan to your patients, you are doing them a disservice. Because what studies are really showing is that what the patient chooses is going to be the best plan for them and the best fit for their lifestyle is the one that is most likely to be successful. So we have a bias, right? This worked for us, or we've seen a study, or we watched a documentary, but we really need to be open-minded and figure out what is going to work for the patient. So macronutrients, diet plans, whatever it is you do, really needs to be individualized. Of course, focusing on healthy themes, and there are certain things like limiting processed foods and refined sugars. A caloric deficit can be achieved generally aiming for at least 500 to 750 calorie deficit per day, which can be about 1,200 to 1,500 calories per day for women. However, I've had a lot of women, especially women on the shorter side, who are maybe less active, who've been through menopause, who need less than that in order to lose weight. We're talking 1,000 calories a day, occasionally 900, which is very little food, right? So it can be difficult when there's this imbalance. Because there's an increased risk for cardiometabolic disease, there are some data and publications out there on the Mediterranean diet in menopause, and they are at an increased risk for cardiovascular disease. So a lot of people do recommend the Mediterranean diet because there is good evidence when it comes to cardiometabolic disease. Exercise doesn't usually result in a ton of weight loss, okay? But it does help with things like sleep and sense of well-being and emotional health and mortality. You want to aim for at least 150 minutes per week of moderate to vigorous intensity, at least 3 days a week, not going too many days without being active, and resistance training, especially for women who've gone through menopause where the decrease in estrogen is leading to a loss of muscle mass. You want them to increase their muscle mass. It will help with their metabolic rate. It will help protect their bones. It helps lower the risk of things like falls and fractures, okay? You can't out-exercise a poor diet, though, unfortunately. And for weight loss or maintenance of weight loss, you might need at least 300 minutes per week. So we're talking 5 hours of this type of exercise per week. So it's a lot of exercise. So of all of those multiple choice answers, one of them was have her work with a dietitian and exercise. Yes, that is a good answer, but she has spent her whole life doing that. And if she comes to you saying, I've tried everything and nothing has worked, and we just say, try again, but this time we're gonna do this diet with this dietitian, we are losing a chance, an opportunity to have a meaningful impact in her life. We have to do something different, okay? And unfortunately, I don't know how many of you are in the primary care setting, but I suspect a lot. Unfortunately, and I think it's because you guys don't have time or the resources at an appointment to really go through this, low intensity primary care interventions to help people lose weight tend to be ineffective and sometimes make patients not want to come back or talk about it. They already have a lot of shame associated with it. So even if all you do is maybe refer them to a higher level of care, I think that alone is associated with greater weight loss at the 1 year mark. So she's already tried every diet and exercise program. These are what I consider to be the 5 pillars of weight loss. We talked about lifestyle, behavioral interventions. I throw everything into there. That's things like self-monitoring, weighing, tracking food, sleep, mental health, making sure they don't have eating disorders, stuff like that, and then medications and surgery. I have this little flyer. I have it at my desk when I'm doing telehealth. I have it in every exam room in my clinic, and I consider it my menu that I offer to patients. So I pull it out and I say, you know, they do an intake form that says what their goals are, how much they want to weigh. Sometimes they want to lose 100 pounds, sometimes they want to lose 10 pounds. And I like to know so that I can try to match my therapy to whatever their goal is, right? And I want to set realistic expectations early on. So I will often say, okay, you put that you are hoping to lose 40% of your body weight. 20% of your body weight. Here's what's out there and what the long-term data shows, but of course, there's outliers to this. So in general, diet and exercise, lifestyle, 2 to 5% total body weight loss at the 1-year mark, and that's with really intense interventions. Medications, so there's some oral medications, phentermine, bupropion, naltrexone, phentermine, topiramate, so Contrave and Qsymia are the brand names. We have injectable medications, Saxenda, Wegovy, and Zepbound, and you can see the percentage of weight loss with tirzepatide in the weight loss version, which is Zepbound being the most effective. We have a gastric sleeve, which is 25 to 30% total body weight loss, and a gastric bypass, which is 30 to 35%. Now, all of these medications and their weight loss, this is at the 1-year mark, generally on the highest dose of medication, right? So we can't set this expectation. And this is also in people who don't have diabetes. Just remember that people with diabetes always lose less weight in clinical trials and in real life than people that don't have diabetes. So these numbers are not necessarily going to apply to your metabolic, advanced, insulin resistance type patients. So the FDA essentially tells us when to consider using a weight loss medication. Currently, it's FDA indicated for a BMI of 27 or above with a comorbid condition, and there's tons of comorbid conditions, or BMI above 30. And the medications can augment weight loss and improve adherence to their intervention. This is getting fuzzy, though. And now there are FDA approvals for things aside for obesity or overweight, and some of them have removed BMI as a criteria. So it's beyond the scope of this talk, but just so you know, if you have someone of Asian background, let's say, who have more central adiposity, who have 4 out of 5 markers of metabolic syndrome, even if their BMI is 26, you could absolutely make the argument that they would qualify for weight loss medication, right? This is just what the FDA says. These are the older medications that we had prior to the last 5 to 10 years, and just comparing their efficacy. And you can see that most of these medications, so this is Qsymia, Saxenda, Contrave, Orlistat, which comes as Ally, and Xenocol, phentermine, which comes in a bunch of different brand names, at the 1-year mark are pretty much all achieving that goal of 5 to 10% total body weight loss, which was considered good, right? That's what was recommended to help with all these medical conditions. One medication that I haven't mentioned because it is not FDA approved as a weight loss medication is metformin. I love metformin. I tell my patients that I think metformin should be in the water instead of fluoride. I don't really know that much about fluoride. I just know a lot about metformin. It's been around for 50 plus years. It's cheap, it's safe, and it has a lot of really good data and not very much not good data. So to me, it's kind of win-win. There is data out there looking at metformin use in prediabetes, menopause, perimenopause, obesity management, and overall, on the spectrum of weight loss medications, it would be the most mild, so at the 3%. The other ones were achieving 5 to 10%. But it seems to improve some of these cardiometabolic markers that we're looking at, like insulin sensitivity, inflammation, blood pressure, mortality, heart failure. There have been some trials looking at cancer risk, and there's some question as to whether or not there's benefit in certain types of cancers, including certain types of gyne cancers. So I like it, and I like it as an intro medication for people who prefer natural things or don't want to be on an injectable or really want to do something that's a little bit more mild and then potentially be more aggressive if they need to in the future. Every once in a while, I have a woman who's going through menopause or is postmenopausal who has this robust response to metformin and loses like 30 pounds. And I'm like, wow, that was easy. That was amazing. It's definitely an outlier, but sometimes it's a good place to start. It's a dose-dependent benefit, okay? So 500 milligrams once a day is not what we're talking about, but gradually working up to at least 1,500, if not 2,000 milligrams per day. And of course, combining it with lifestyle interventions. All interventions for weight loss work better when coupled with each other. Whether it's a GLP injectable or a pill, combining it with dietary changes and exercise, using it as a tool to make those types of changes is going to have the maximum benefit. Now, here are the injectable medications. These are GLP-1 agonists. There's so much confusion that I had to make the slide, and I have to update it all the time as there's constantly changes being made. I basically highlighted in yellow all of the medications that are FDA approved for the treatment of obesity. I don't know why there's so much confusion and people think Ozempic is an obesity medication or Mounjaro. It's not. They're not. They're only FDA. Ozempic and Mounjaro are only FDA approved for the treatment of diabetes. And Ozempic and Wegovy are the same medication, same manufacturer, same formula, same medication. Mounjaro and Zepbound, same exact medications, formulas, same pen delivery devices, same drug company, same doses, just different names based on FDA approval. I think they're starting to figure out that name recognition maybe would have been more helpful, and so now they came out with an oral version of semaglutide for weight loss, and they're calling it oral Wegovy, whereas the oral version of Ozempic is called Rybelsus, not Ozempic. If you guys can't keep up on this, I don't blame you. This is a full-time job. This is my job. This is my full-time job. And figuring out how much these all cost is also my full-time job. So these are the 3 FDA-approved medications. We talked about subcutaneous Wegovy, average weight loss 16%, PO Wegovy being a little bit below that, and Zepbound 22% at the 1-year mark, all on the highest doses, assuming patients are able to tolerate this in these higher doses. I could spend an hour talking about GLP, the mechanism of action, why these are wonderful molecules, but all I will say is aside from helping people lose weight, they are improving so many other aspects related to quality of life and a lot of things that affect women in menopause, right? They can affect sleep apnea or difficulty sleeping, inflammation, joint pain, liver disease, dementia. This is going to be the wave of the future right now. It's a very exciting time, and over the next few years, you guys are just going to see more and more use of this. So it is exciting. Now, what type of weight loss do we see? And like I said, with the highest dose of semaglutide, so this is Wegovy, not Ozempic, you are seeing once they ramp up at the 1-year mark, an average weight loss of about 16%. But what's exciting is if you break down the patients that were able to tolerate the medication and stayed on treatment, you can see that over a third of them were able to lose over 20% of their body weight, which is really exciting. A lot of people compare these medications to weight loss surgery, and I'm going to show you why I disagree with that, but these are still really great options, especially for someone who doesn't qualify or want surgery. Tirzepatide, this is looking at Zepbound at the maximum dose of 15 milligrams per week, about 22% total body weight loss. But even more exciting here now, there's a column for 25%. 40% of patients who are on the highest dose, that's 15 milligrams per week, at the 1-year mark were able to lose more than 25% of their body weight, which is fabulous. What about hormone replacement? Couldn't we just give her hormone replacement to help her lose weight? As you guys have heard, generally speaking, hormone replacement does not result in significant weight changes. However, it does affect weight distribution. So it can improve lean body mass, insulin resistance, cholesterol levels, and that central weight gain can have some level of improvement. But it is not recommended as a treatment just for weight loss, but you can use it for treatment of other conditions that we heard about all day today. What's really interesting, though, is there have been a few small trials that have been looking at hormone replacement in the setting of also using weight loss medication. And it seems like being on hormone replacement augments the response to GLP agonists. And this is exciting. So now, perhaps, I don't know if you guys are hearing, a lot of people are starting to say the best treatment for menopause is hormone replacement and a GLP-1 agonist. And this might be where we are going, especially if people are worried about things like cancer risk and cardiovascular disease, because the GLP medications seem to mitigate some of those concerns. So this is looking small amount of people, so only about 100 patients. It was a retrospective cohort study looking at women who either were on hormone replacement or weren't, and semaglutide. So this is Wegovy getting up to the maintenance doses of at least 1.7 or 2.4 milligrams per week. And you can see that the women who were on hormone replacement lost more weight than the women who were not on hormone replacement. And that's exciting. And especially in the losing at least 5 to 10% of the total body weight, the women who were on hormone replacement, a greater percentage of them were able to achieve that goal. Now, a study came out, this was at the Mayo Clinic, 120 women who looked at this, but with tirzepatide. And they found similar things, that participants who were on hormone replacement had a better response. And I like looking over here on the right. The blue are the patients who were on hormone therapy, and the salmon are the people who were not on hormone therapy. And you can see not only was the average weight loss lower in the blue group, but they had a much higher percentage of people who were losing 30 or 40% of their total body weight, which is really exciting. There's a lot of pros to the medication. There's a few cons. Of all the cons here, I put asterisks next to the ones that I think can be influenced by titration, lifestyle changes, the way that they're eating and drinking. So to me, these are more modifiable. My biggest issues is it used to be that patients didn't want to go on a medication. Everyone wanted to do it themselves. I want to do something natural. But now everyone wants these medications. Like I want Ozempic, I want what Oprah is taking, like Kelly Clarkson or Kim Kardashian. You know, I love naming all the celebrities who've like come out as openly speaking about this. But so now people want it and they can't get it. And that's because insurance companies don't want to cover it. Partly because in this country for most of my lifetime, obesity has been considered a cosmetic concern and has not been covered by insurance. Medicare is really who sets the tone. So once Medicare starts covering things, a lot of times other commercial insurances will follow. I mean, it's only within the last 15 years that Medicare started covering weight loss surgery, and now 95% of commercial insurances cover it. Now, weight loss medication is still a carve-out, and sometimes it's up to employers, not insurance, and the cost is so high that I've heard quotes saying it's going to like bankrupt our healthcare system if all patients with insurance were getting coverage for it. But also, unfortunately, insurance is completely for profit for most of these commercial insurances, and that's a huge problem because they don't want to spend money. And everyone's like, well, wouldn't it be better to prevent disease? Like, don't they want to spend the money now to prevent the disease? But you have to remember, by the time patients develop disease, they're no longer working at whatever, Boeing, and now they're 68 years old, they're retired, and they're on Medicare, and it's Medicare who's going to have to pay for the heart disease and the diabetes and those complications associated. These are just my philosophies. I don't know if this is completely accurate, but that's how I feel. I do think that there's a lot of advocacy around this and that things are improving in the coming years, but hopefully insurance will start to cover it. But the companies know that insurance isn't covering it, and the cash pay programs are getting better. Medicare will cover tirzepatide. It is FDA approved for moderate to severe sleep apnea with obesity. Semaglutide under Wegovy is approved if someone had a history of MI, stroke, or peripheral vascular disease, or now a newest indication is related to MASH, so liver disease. And you're just going to see more and more approvals for different conditions. There's coupons that you can bring to local pharmacies. There's also mail order pharmacies that have certain types of medications, such as vials that you can't get at local pharmacies. There's auto injector pens and adjustable pens. It's so complex, but I will just say that there are two kind of direct to consumer, although they still need prescriptions, but there are two pharmacies made by the major drug companies. So Novo makes semaglutide, Lilly makes tirzepatide, and you can send, if you go into Epic and you put in NovoCare, you can send a prescription to NovoCare to have patients have it sent to their home, and same with Lilly Direct. So what if Michelle will only use the medication short term? They studied this. This is with semaglutide. They gave everyone the medication in a run-in period, and then 50% were continuing the medication at randomization, 50% went to a placebo. And these are people who had just lost weight on medication. They were working with dietitians. They were meeting with a clinical researcher, and they regain the weight when the medication is stopped. At least 80% of the weight is regained, or the people regain that weight. And the same has been seen with tirzepatide. And I have patients who say, I'll take it, but then once I learn how to eat properly, I will continue those habits and keep the weight off. And unfortunately, your brain is smarter than that, and the weight comes back. So these are long-term, forever things, but they also are prevention, right? And so I'm often telling patients, taking this medication is going to prevent X, Y, Z, and honestly, for a lot of patients, help them live longer, healthier lives. If she really wanted to lose more than 25% of her body weight, we should start talking about surgery. I think surgery is an area that we could really be exploring more, such a helpful, life-changing tool for so many people, but a lot of providers are against it, patients are against it, and I think there just needs to be maybe more education on it as well. But of course, no one wants surgery, right? No one's like, I want to be cut open and have my intestines rearranged. But when you start looking at the data on how significant the improvements are after surgery, I think people will open their minds to it. So here are the FDA approvals, but this is also different with different insurance companies. They all have different comorbid conditions that qualify them when their BMI is between 35 and 40. Overall, the total weight loss and the weight kept off long term is the highest in people who have a gastric bypass. hands down. And we're looking at the 30%, 25%. And this goes all the way down to 20 years post initiation of the study. The reduction of conditions after weight loss surgery, because so many conditions are weight dependent and there's such significant weight loss, it's so robust. And here's things like urinary incontinence, dementia, mortality, cardiovascular disease, things that affect women with menopause. Now, metabolic surgery and obesity medication are not mutually exclusive, so you can start one and then do the other. You can do one and then sometimes need to do the other. So I want you to always keep them both in mind, since we know lifestyle doesn't work. I also want you to know that this slide took me 18 hours to make. So I don't care what topic I'm talking on, this slide is going to be in every slide deck I ever present. So we're back to Michelle, right? She struggled with her weight. She's tried everything. What can we do? Aside from only doing A, I think all of these are reasonable options. It depends on her insurance. It depends on her preference. It depends on her risk factors, contraindications. So you really need to go through. At the end of my slide deck, I threw in some extra slides, and there's some tables about the different medications, things to look for, contraindications in case you want to be prescribing more weight loss medications. So just remember, changes in hormones leads to the central fat distribution and weight gain that can increase the risk for metabolic disease. While hormone replacement can have favorable effects, it's not recommended as a sole treatment just for central obesity. We're going to use the 5 pillars for successful weight loss. We have this awesome clinic within Scripps you are welcome to refer to. My biggest takeaways, though, are that obesity is not a choice or a matter of calories in versus calories out and willpower. We want to help people improve their health, lower their risk of disease, live better lives. There's no one-size-fits-all. Please just make sure that you are approaching them with compassion and empower them with data and offer evidence-based solutions. I am the co-director of an obesity conference at Scripps. We had our first conference last year. We have our second conference this May. It's Saturday, May 16th. So if you want to learn more about obesity, it's just a day dedicated to learning more about it. So please come. We'd love to see you. That's all.